Go over these slides a little bit with you. So one of the things about the vesicular or bullous diseases I've tried to hammer home to you is if you start getting blisters anywhere on your body or bulla, vesicles, and it's not attributed to something like poison ivy or a bug bite or something that you can attribute it, herpes, for example, that you can attribute it to a physical thing. If you start getting blisters for no freaking reason whatsoever, you need to biopsy it. Okay, you need to biopsy it. And the reason for it is, depending on where the split is in either the epidermis or the dermis or the epidermal-dermal junction, will determine what the hell it is. You won't be able to eyeball it and tell. I can't eyeball it and tell. So you have to send it off to the person with the microscope who will be able to eyeball it and tell. So that's what's the most important thing about vesicular and bullous diseases. And I'll go through and tell you the other pertinent points about it now, and then give you a donut break, and then we'll do a review. All right, so the three topics we're going to go over quickly here is pemphigus, bullous, pemphigoid, and dermatitis herpetiformis. I need a donut. So, remember back to the first lecture, we're talking about primary lesions. Hint, hint, know the difference between primary, secondary, and special lesions. Vesicles and bulla are primary lesions. So they're not something that happened to them, not trauma to a primary lesion, and they're not one of those 6 or 7 things that are special lesions. So you need to do some things to try to figure out what this is, and it's not poison ivy. So you biopsy. It's a primary lesion. It's an autoimmune issue. So how do you think you're going to treat them? Or somebody, a dermatologist or immunologist is going to treat them. They're going to give them some antibodies. It's an autoimmune type issue. Most of them is IgG, along with some other medications, a few steroids. One of them, the dermatitis herpetiformis, is an IgA problem. All the rest of them, so memorize the short list. Dermatitis herpetiformis is an IgA problem. All the rest of these things are IgG problems. There's 6 or 7 of them. It's going to be on a slide in a minute. You don't got to memorize them all, just remember that part. So it's impaired. What happens is, besides this is an autoimmune problem, it starts making your skin separate in different places, either in the epidermis or the dermis, not down to the subcutaneous level. And depending on where it separates, let me steal some of the thunder from these next slides. You get blisters, right? So if it's in the epidermal area, and you're going to get the Nikolsky sign with any of these things, right? Where your skin starts sloughing off if you touch them. If they're in your epidermis and you mess with them, they're going to easily burst. It's like a little, little thing, you touch it and it bursts. That's one of the physical exam findings for something that ain't as bad as the other. If it's in the dermis, you think you're going to burst it by touching it? No. And the fluid is going to be more hemorrhagic because that's where blood vessels are, is down in your dermis, where the vesicles that are on your epidermis are going to be kind of serous sanguineous. So that's some of the physical exam findings besides doing a biopsy that will help you try to figure out if it is pemphigus vulgaris, pemphigoid, or dermatitis herpetiformis. So, if it has this, here's another little tidbit for you. If it has the name herpes in it, like shingles and herpes, it's going to burn, it's going to itch. Those are other physical exam findings. These other 2 bullous diseases don't burn or itch for the most part. Dermatitis herpetiformis that you biopsy does itch. All right, so look at all that big scary picture there. There's all shows different levels of the epidermis and dermis it impacts. All of those are IgA except for the last one. IgG except for the last one, which is IgA. So don't let the picture scare you. Pemphigus, all those different types of classifications are different types of pemphigus. It's an autoimmune issue. Also, it's intraepidermal blisters. Again, top level of the skin. IgG antibodies. This is for Gunny here. Near universal involvement of the oral mucosa. Like 99.9%, pemphigus vulgaris is going to show up with little blisters that rupture very easily inside your mouth. All right, that predates the ones that are going to show up on the rest of your skin. The other ones don't present like that. So, you see a picture like that in the near future, that's it, Gunny. Now, we need a couple of you guys to take one for the team on this, so that James doesn't show up in the test committee because there's too many 100% right answers. All right? All right. Guess today's my last day. Except for Friday. All right. It's a primary lesion. It doesn't itch. These other ones itch. This one doesn't itch. Again, it starts in the mouth. It goes other places after a couple of weeks. It has an Nikolsky sign, means it sloughs off. And when they coalesce, they look nasty like that. Now, don't worry about these next couple of pictures. All this is supposed to jiggle in your brain is, you need to biopsy it. Those are just pictures of different areas of where you biopsy it. How do you determine where to biopsy it? If you don't send it to the dermatologist and they biopsy it, they will tell you where to biopsy it. And they use this type of picture to determine what they're looking for. So this is just biopsy holes in different places. If you don't have this, and you don't have a dermatologist, and you need to biopsy it because you're deployed or whatever, remember kind of what I said, you take a piece of the blister and a piece of the skin next to it, if you have to do that. Otherwise, you'll listen to this. Treatment, refer to dermatology. Give them some IgG, give them some of those other medications. You won't be doing any of that. You might be on the back side of it, where they've seen a dermatologist, they've done the biopsy, they've infused them with some IgG, and you might be giving them some systemic glucocorticosteroids or something as a management after they've already been discharged. That's where you'll fall in the picture. But for exam purposes, this is part of the picture. All right. Bullous pemphigoid is the most common one. It is subepidermal. That's the difference. This one's not intraepidermal. This is below the epidermis. That's why the vesicles with this one and the bulla with this one do not rupture as easy, because they're deeper in the skin. That's why when you look at the blisters or the bulla, they'll be kind of bloody. They won't be clear. All right. Begins with some redness. It itches. Look, the other one didn't itch. This one itches a little bit. Vesicles appear, and they're tense. They're hard to rupture. Fluid may be clear, but hemorrhagic too. And here's the pictures. See how some of those look like blood blisters on the, on the tricep area down there? That's not pemphigus, that's bullous pemphigoid. Now, would I know that by looking at it? No. I wouldn't expect you to. Again, scary picture. This means you need to put a hole in it, send a piece of tissue off for somebody to figure it out. Treatment, steroids, and the same treatment for this was for pemphigus, IgG, not IgA, and all the other medications, oral steroids, that kind of thing. They need, it's an autoimmune problem, so you're going to give them antibodies. It's a real bad case of it. You can imagine the morbidity and mortality when people start getting this stuff, blisters like this, it's big time. They're going to be in the hospital. They need to be in the hospital. So if you start seeing blisters popping up for no reason, send them to the hospital, burn unit, all that other kind of stuff. I've personally never found this, even though every time I saw a blister, and I was working with a dermatologist, and we couldn't attribute it, we always biopsied it. It never came back as this. So I can't say, yeah, I found it, I'm a hero. I'm a zero, I'm the domain guy. I've never found this, thank God. This is the one, itchy burning related to, kind of shows up kind of like herpes might show up. Dermatitis or pediformis. Most commonplace this shows up to begin with is it on extensor surfaces, kind of like psoriasis, elbows and knees. You don't know why. That's where it normally kind of starts showing up. Begins as papules, turns into vesicles, intensely burning, itching, typically group like herpes, usually on extensor surfaces. All right. Diagnosis again, this one, punch biopsy, vesicles, punch biopsy. Not going to be worried about the treatment on that. Dermatitis or pediformis, and that's it. So, my computer did not die. That's the last lecture for this block. So take a little donut break, 5 or 10 minutes, and then I will